Dear colleagues, in partnership with the Société Francophone de Nephrologie, Dialyse, Transplantation, die Österreichische Gesellschaft für Nephrologie und die Deutsche Gesellschaft für Nephrologie, Marcus at Home welcomes Professor Thierry Lobbedez and Dr. Clémence Béchade in Caen, Normandy, France, for an update on peritoneal dialysis, PD, focusing upon two topics, namely assisted PD treatment and the use or non-use of anticoagulation in PD patients. Dear Thierry, dear Clémence, a pleasure to host you tonight for our second stage of our tour académique. The tour will arrive in Bretagne, but we're still in Normandy, so thanks for joining us.
Dear colleagues, the Tour de France is going through Caen this year, and in France, when we think about Caen in the nephrology field, we think about clinical epidemiology in CKD and peritoneal dialysis. So today with Gunnar and our two co-moderators, Dr. Martin Windpessl, who works in Wels, who is the secretary of the Österreichische Gesellschaft für Nephrologie, the Austrian Society of Nephrology, and Professor Andreas Vychytil, who works in the Medizinische Universität Wien, and who is one of the leading experts of PD in Austria. We are very pleased to have both experts from Caen. So Clémence Béchade. Clémence Béchade is assistant professor of nephrology. He is a specialist of PD. She is very implicated in national and international expert groups, especially the ESPD. She works on assisted PD in socially deprived patients and on anticoagulation in peritoneal dialysis. This is what she's going to talk about here. And Professor Thierry Lobbedez, who is a long-standing expert in home dialysis, especially peritoneal dialysis, who leads an internationally expert team in epidemiology with specific focus on home dialysis, and he will talk about assisted PD. So to start, we'll start with Clémence. So Clémence, what can you say about anticoagulation PD, given you are an expert who is leading the EPIDP randomized controlled trial in this field?
Thank you very much, Dominique, for the introduction, and good evening to everyone. I'm very pleased to give this talk today on anticoagulant treatment for peritoneal dialysis patients, and in particular, I will focus my talk on atrial fibrillation. So atrial fibrillation is a disease that is particularly prevalent in our CKD population, as we know that age, ethnicity are risk factors for atrial fibrillation. And we also know that CKD is another risk factor for this disease. In a publication that was published more than 15 years ago in patients on having a CKD, it has been shown that the prevalence of atrial fibrillation in patients with CKD was around 20%, while it was around 6% in the general population. And of course, we all know that the risk of atrial fibrillation is to have embolism, and in particular, stroke. So that's why we need to give anticoagulant treatment in patients with atrial fibrillation. And the other risk due to this anticoagulant treatment is to have bleeding. And in this Danish study, published also more than 10 years ago, in a cohort of patients with atrial fibrillation, they have reported that both the risk of stroke and the risk of bleeding are increased in CKD population in dialysis or not on dialysis compared to patients with atrial fibrillation but with normal kidney function. So we have several options to prescribe an anticoagulant treatment to a patient at the moment. So we have vitamin K antagonists, and we all have prescribed warfarin for years. And for a shorter period of time, we now have the possibility to prescribe another class of treatment with this direct oral anticoagulant. We have two types of direct oral anticoagulants, dabigatran, which targets the factor 2, and the factor 10 inhibitors, so rivaroxaban and apixaban. These two categories of treatment have some some indication in common, but you can see also that some situation or indication for vitamin K antagonists, but not for direct oral anticoagulants. And in particular, the valvular disease, the context of mechanical heart valves, is not an indication for direct oral anticoagulants, whereas it's an indication for vitamin K antagonists. And also, we should remind that pregnancy and breastfeeding are contraindication for direct oral anticoagulants. So we have challenges to face with in the context of anticoagulant treatment in CKD. Concerning vitamin K antagonists, we have multiple food interactions and also drug interactions. And we all know that patients in CKD have a prescription of generally a large number of medications. We also have a narrow therapeutic range, and the vitamin K antagonist requires a regular monitoring of the YNR. And we know also that the risk of bleeding is present also in a patient with a good anticoagulation control. On the other side, for direct oral anticoagulants, we have less food interaction, but we still have drug interactions. We should have in mind that there is no anticoagulant reversal, and it's something to keep in mind, in particular in the context of waiting for a deceased kidney donor transplantation, as in the context of unplanned surgery, we can't stop rapidly the effect of this direct oral anticoagulant. And we should mention the specific metabolism of direct oral anticoagulants. As you can see, these treatments are eliminated through the kidney, while vitamin K antagonists are mainly eliminated through the liver. So you can see that dabigatran has an elimination that is highly through the kidney. More than 80% is eliminated through the kidney. So this drug is not recommended in CKD. And concerning rivaroxaban and apixaban, you can see that it's around 30% of elimination through the kidney function. So that's why during the first studies with oral direct oral anticoagulant, the CKD patients were not included. Fortunately, we now have data in this population. So while in the general population, direct oral anticoagulant are superior to vitamin K antagonists in concerning the risk of embolism and the risk of bleeding. In the CKD population, the studies have shown that the risk of embolism is similar with direct oral anticoagulant compared to vitamin K antagonists, but the risk of bleeding is lower with apixaban compared to warfarin. So there is a superiority of this treatment regarding the risk of bleeding. We also have data in hemodialysis with at least 3 randomized control trials with randomization of direct oral anticoagulant versus warfarin. All the results are not similar, but we should note that the dose of direct oral anticoagulant was not the same in the different RCT. So that's also the reason why the meta-analysis I show you does not show something, and the conclusion of the meta-analysis was that the risk of bleeding and the risk of embolism was quite similar in hemodialysis. And what about peritoneal dialysis? So the things observed in HD can't be the same in PD, and for note, we should say that the residual kidney function is is preserved for a longer period of time in PD, so that's a big difference with HD patients. And we have seen that the elimination of direct oral anticoagulant is partly through the kidney function, so it might have an impact. The risk of bleeding is also different in PD. We don't have any vascular access and risk of bleeding or hematoma here. We don't have any injection of heparin in PD compared to hemodialysis, so it makes also a difference. And we don't have access to the blood, not so easily as in hemodialysis. So we should also be concerned by the several blood samples that are needed to follow up a patient with vitamin K antagonists. And we all know that we should preserve the veins, and think that a PD patient could one day require vascular access for hemodialysis. So it's also something we have to note. So that's why we have published the first study, a PDP study, which was a pharmacokinetic study where we gave one pill of 5 milligrams of apixaban in 12 PD patients, and also in 12 volunteers with normal renal function. So the objective was to see how the treatment was eliminated. So you can see here on the graph that the concentration in the blood of apixaban was achieved, the maximum was achieved after 3 to 4 hours in both groups. So in blue it's the PD group, and in dark it's the normal kidney function group. You can see that the peak is higher, so the concentration of apixaban was higher in the PD group, and also that the area under the curve was increased in the PD group, more than 70% of increase compared to the normal kidney function group. And also it was a surprise to see that only 0.1% of the dose administered was present in the dialysate after 1 day, so the elimination through the PD solution was low. So that's why we concluded this study talking about a reduced dose of apixaban in PD, as a normal dose is usually 5 milligrams twice a day. And regarding this research, we think that a reduced dose of 2.5 milligrams twice a day should be prescribed in PD. So we are now conducting a second study called APDP2, which is a phase 3 study where patients are randomized between 2.5 milligrams of apixaban twice a day versus warfarin. So in patients with atrial fibrillation without any valvular issues. And it's a security study, so the primary endpoint concerns bleeding. So the primary endpoint is a composite of major bleeding or clinically relevant non-major bleeding. So it's not a double-blind study. Both the patient and the nephrologists are aware of the treatment received, but the event is classified by an adjudication committee that is blind to the treatment received. And we also have secondary endpoints, particularly on stroke events. So we will include some adult patients in PD for more than 3 months having a non-valvular atrial fibrillation and a SHATBAS, so a score requiring anticoagulant treatment. And there is a randomization between these two treatments, and each patient will be follow-up for 1 year. So I don't have any results to show you now. We have to wait until we know what is the best option for our PD patient. We have to include more than 170 patients, PD patients, so it's a big challenge as the number of PD patients is not so high in France, and we have to find these patients, this PD patient with atrial fibrillation that can be included and that are agreed to participate. So I hope I will have some results to show you in a few years. Thank you for your attention.
Thank you very much, Clémence, for this great presentation. Maybe we can start the discussion with Dr. Windpessl.
Thank you. Well, our National PD Working Group is in the process of drafting recommendations for the management of PD patients with AF in terms of anticoagulation. And when we set out, it quickly became apparent that this is an almost evidence-free zone. So I would like to thank you for trying to close this evidence gap with your studies. Perhaps I may start with comparing your protocol with that of another high-profile study in the field, SAFE-D, recently published in JASN, and by the way, also including, I think, 11 PD patients, about 7% of the study population. And although this study population was ultimately successful in proving feasibility of such a trial, it noted major difficulties in terms of recruitment. You alluded to it, with a substantial proportion, about 200, unwilling to participate. And this is also evident from other studies which did not kind of fulfill or could not recruit enough patients. I noted in preparing for this discussion today that Avdial was terminated prematurely because of poor recruitment. So how are you going to address this challenge, which seems a constant hurdle?
Well, yes, I'm still confident, but it's of course a very good question. The first thing is that we will include both patients having a new diagnosis of atrial fibrillation and patients with a history of atrial fibrillation. So patients who will maybe have a switch in terms of type of anticoagulant treatment, and patients with a new diagnosis, so prevalent and incident patient with an atrial fibrillation. So I hope it will increase the possibility to include patients. That's the first point. The second point is that many centers have been contacted before we launched the study. So I have to say that PD is only 6% of the patients on dialysis in France. So it means that the challenge is big, but the teams are very enthusiastic. We all know each other, and when we went to this period of is the study feasible, we call our colleagues everywhere, and we had many answers for agreement of participants. So we have, as you can see, I didn't mention it, but more than around 40 centers that agreed to participate. So I hope we will have at least a large number of patients during the first year, and maybe we will have to conduct the study to increase the period of inclusion. That's maybe possible, but I'm still confident, and I hope we will have recruitment.
Gunnar, do you have a comment or a question?
Well, yeah, one question which is, I guess, a problem to all of us, and you mentioned that in your talk when stating that some of us are reluctant to give drugs to either PD or HD patients who are on a transplant waiting list. And I'm aware that quite a couple of German transplant centers do not accept, or at least are very reluctant to accept, people with NOACs. And there have been also some, well, issues from Austria that have been published some months ago. My personal opinion is that the evidence is so clear against vitamin K antagonist that using vitamin K antagonist is actually no longer an option, and that we would have to decide whether to give NOACs or no anticoagulation at all, as proposed by Anne Vries some years ago. But how do you do in France? So having these concerns, do you have centers that really do not accept people on NOACs?
So I didn't have enough time to detail all the inclusion criteria, but registration on a waiting list for a transplantation from a deceased donor is an exclusion criteria in our study. So it's something that we have decided, and that was also looking by the ethical committee. So a patient on the waiting list for a deceased donor transplantation can't be included in our study. We have patients waiting for a living kidney donor. So here it's possible because we know when the operation will take place, and we can stop the direct oral anticoagulant treatment just before. So this person can be included. And also when it's the period of evaluation for deceased kidney donor transplantation, the patient can be registered, but as he is on the waiting list, active on the waiting list, then he should be excluded.
And in clinical practice outside of the study, how do you do? Maybe also how do you do in Rouen and in Austria right now?
In Caen, we don't give apixaban in patient waiting for a deceased kidney donor transplantation. I don't know in Rouen, Dominique, but...
We don't either.
And in Vienna?
Yes, it's the same in Vienna. So patients at the waiting list receive no NOACs.
So then I'm grateful to our Frankfurt Transplant Center who do accept, because it makes life in my eyes much easier. One more question from my part. So you nicely showed the pharmacokinetics that you would have, if I remember correctly, 70-something% increase in the area under the curve. Did you ever consider to use even lower dosages than twice 2.5 milligrams, like once daily 2.5 or twice daily 1.25 milligrams, which also has been proposed by some people in the field?
Well, so I'm not a specialist for this, for pharmacokinetic, but there were some specialists in our team. And in particular, I showed pictures of my colleague Laure, who is a pharmacist. And so several hypotheses have been proposed by the pharmacist, but the one that has been considered as the best option was 2.5 milligram twice a day. So they have evaluated several propositions, but the pharmacokinetic specialist said that it's the best option according to them.
I have one other question. So one option would be to give no anticoagulation. I'm not aware of data comparing NOACs with no anticoagulation. So would this be an option not to anticoagulate, which is done in many centers?
Yes, thank you for your question. So we also mentioned in the inclusion criteria that even if there is an atrial fibrillation and a score, a Schatz-Vaz score, that answers that this patient should receive an anticoagulant treatment, the nephrologist can decide not to provide an anticoagulant. So we have listed some clinical issues that may explain this choice, in particular old and frail patients with a lot of falls at home. So I don't have any data to show you on that, but of course we think that even if the Schatz-Vaz score is more than 2, even if there is an atrial fibrillation, in some situation we will decide not to provide any anticoagulant treatment, because the risk of bleeding is, of course, we all know that it's an important risk, and that so maybe with direct oral anticoagulant we will consider some situation with new aspects. But at the moment, I agree that in some situation we are not very kind to prescribe anything.
Thank you, Clémence. Maybe a last question for Dr. Windpessl?
Yes, I've got a question about established stroke prediction models which perform poorly in the dialysis cohort. And the limitations have been recently highlighted, and I presume that it was no coincidence that the first practice point made in a review article, first author is Professor Heine, was that we should not uncritically apply these scores for the dialysis patients, although it's done in safety, for instance, as well. Given the surprisingly low event rate in safety with one stroke occurring in 6 months in the study period, don't you think this is a central issue? Perhaps we should try to use this dialysis risk score proposed by De Vries, which omits hypertension and heart failure, basically, and kind of finds a higher risk population, which perhaps would benefit from anticoagulation more than more generic PD patients. In this review article, the authors kind of estimate that about half of the whole study cohort, which would qualify for anticoagulation according to Charles Rusk, would not qualify for anticoagulation if the dialysis risk score was applied instead.
Yeah, I think that the recommendation coming from cardiology are not providing enough details for our specific population in CKD, dialysis or not on dialysis. But as you mentioned before, I think we need to have maybe more studies in that specific populations to because maybe the tools that we use in the general population are not well fitted to our specific patients.
So we need these studies. These studies are difficult to do, so you must be really commended for this. Thank you very much, Clémence. For the sake of time, we have 2 speakers today, and we're very lucky to have Professor Lobbedez, Thierry. So Thierry, can you take the floor talking about a short update on assisted peritoneal dialysis?
Thank you for this nice introduction and for the invitation to give this talk, which is, let's say, my favorite topic. So to begin with, I would like to thank all the members of this group who have done a really great job in writing this position paper for the ISPD about assisted peritoneal dialysis. So the first step was to come up with a clear definition of assisted PD and then to provide a justification for assisted peritoneal dialysis. So we decided to focus only on assisted PD that is funded by the healthcare system. And so in the position paper, assisted PD was defined as PD performed at the patient home with the help of a paid family member, a technician, or a community nurse. As you know, there are different models of assisted peritoneal dialysis. This model differs in terms of the task covered, the number of visits per day, the location of the assistance, and the duration. But I think that we all agreed in the group that catheter manipulation is one task that is really important because it can influence the patient outcome, and so that it should be covered by assisted peritoneal dialysis. The first justification was the fact that caring of patients with end-stage renal disease is very complex, especially because we have moved over the last decade from the comorbidity model to the multimorbidity model, where there is a lot of interaction between the different morbidity, and these interactions have a greater impact on the patient health than one comorbidity alone. In the older end-stage renal disease patient, there's also the problem of the interaction between the functional impairment, the cognitive dysfunction, and the disease burden. And this type of interaction can dissuade the patient from choosing PD. It has a negative effect on the family members. It can increase the PD complication and affect the technique survival. The second justification for assisted peritoneal dialysis is the lack of availability of the family assistance. In this study with the French data, we demonstrated that the rate of family-assisted PD decreased regularly over 1 decade. This could be partly explained, I think, by cultural norms, by changes in cultural norms that leads to a lack of family helpers. There's also the problem of the social isolation, which is obviously higher in the older population, and this leads to a lack of family assistance. One of the last problem is the effect of peritoneal dialysis on the family caregivers. In this study from Singapore, from a Singapore team, they examined the effect of peritoneal dialysis on the quality of life of the family caregivers, and using a specific scale, they showed that the burden of the disease on the family members increased after 3 months of peritoneal dialysis. And looking at the task assigned to the family members, they showed that the involvement in doing dialysis, in providing personal care, decreased after 3 months of peritoneal dialysis. So I think that we can say that the quality of life of the family caregivers may influence the outcomes on PD, and that's another justification for assisted PD. I also want to draw to your attention the fact that there's no equity, in fact, in the dialysis choice. In this study, we showed that the women are more frequently treated by nurse-assisted PD than men, and this is probably explained by cultural norms that are very difficult, often difficult to change, to modify. And so we believe that assisted PD could help to reach a sort of gender equity in the choice of the dialysis modality. What is now the effect of assisted peritoneal dialysis on increasing PD uptake? During the information process, the availability of assisted PD can help the individual to choose PD, but also the dialysis team or the pre-dialysis team to provide information about PD during the shared decision-making process. In this study, this work, they explore how preconception about PD can act as barrier to peritoneal dialysis, and what they showed is that physician and nephrologists would have more confidence on PD if they can offer assisted peritoneal dialysis, in particular in the frail and elderly patient. In this study done by Maitre from Canada, they looked into the contraindication to self-care peritoneal dialysis. And one of the main mental and psychological barrier was the patient anxiety. The SONG study revealed that PD-related infection is the main priority for the patient and their family. So we can assume that the fear of peritonitis can increase the anxiety, which could influence the choice for PD. And I think that the assisted PD, if we could provide assisted PD, we could decrease the patient anxiety when it's the time to make a choice. Anxiety is very common in a CKD patient during the pre-dialysis process. In this work, they show that 45% of the patient choosing PD experience anxiety, and 29% of the patient choosing HD. And we demonstrated that in previous studies that nurse-assisted PD is associated with a lower risk of peritonitis, especially in the elderly. In diabetic patients, nurse-assisted PD is also associated with a lower risk of peritoneal infection. And we also demonstrated that the risk reduction in diabetic patients is due to a lower risk of errors during the manipulation of the PD catheter. So we believe that this piece of information can be provided to the patient during the information or during the decision process to decrease the anxiety. It shows that they can receive help, and I think that this could decrease the anxiety. We all know that the dialysis care, the conservative care is an option for the ENSRD patient. In this study, they investigate the factors associated with the conservative care preference among Australian patients with CKD, and the number of visits to the hospital for the dialysis session and the travel restriction were associated with the conservative care preference. I think that supportive peritoneal dialysis is an option that could help the patient to choose supportive assisted PD over in-center HD and supportive assisted PD over the palliative care or the conservative care. In this supportive PD program from the UK, patients undergo 2 PD exchanges per day, 5 or 7 days per week, and they are helped by an healthcare funded assistant. Patient well-being after 3 months of supportive PD improves in terms of anorexia, tidiness, shortness of breath, which are obviously the main criteria in this specific population. If we look at the flow chart of the supportive PD program, of 49 patients enrolled in the program, only you can see that only 1 patient was transferred to HEMO. 13 patients passed away in the program, which was, let's say, a kind of success in this particular situation. After the choice of the dialysis modality, the availability of assisted PD helps to overcome the barrier to PD, which are mainly physical barrier or cognitive barrier, but also the barrier related to the unplanned dialysis start that occurs in approximately 1/3 of the patients starting dialysis. Again, this study from Canada, they showed that of the patient eligible for PD, they are 50% of these patients who have a contraindication to self-care PD, and these contraindications are mainly physical barrier to self-care. We also investigated the nurse assessment of the ability to be treated by self-care PD, and you can see that again, functional impairment, cognitive dysfunction, and dizziness or visual impairment were associated with the utilization of nurse-assisted PD. So basically the same criteria. The late referred patients are most of the time treated in-center HEMO, and we think that short-term and long-term assisted PD can help the unplanned dialysis starter to start on peritoneal dialysis. We know that the unplanned dialysis PD starter have lower tactic survival than the PD plane starter. This is because these patients did not receive any counseling or education or training about home dialysis. And so they probably have some difficulty to cope home dialysis. This assisted PD may help this patient to start on PD. In fact, this was suggested by Johan Poulsen from Denmark in this first paper where he report his experience about the program, the assisted PD program for the late refer elderly patient. You can see that in their program, 62% of the unplanned PD starter were in fact treated by assisted peritoneal dialysis. In our program, we follow the same practice. You can see that among the acute PD starter, half of them were treated by nurse-assisted PD after being discharged from the hospital. In this paper, they examine if they compare a region with no home care with a region with where home care was provided. And you can see that when home care is provided, the number of patients eligible for PD is higher, as did the number of patients treated by peritoneal dialysis. In this single center study from the UK, you can see on the graph that the rate of PD was declining during several years. At the time they implemented an assisted PD program, the number of patients or the proportion of patients treated by peritoneal dialysis increased. Assisted PD can also increase peritoneal dialysis duration. We demonstrated that nurse-assisted PD was associated with a lower risk of transfer to hemo. And we recently published the fact that this protective effect is time dependent. That means that at the beginning, during the first 6 months of PD, assisted PD is not protective. It becomes protective after 6 or 12 months on peritoneal dialysis. So to conclude, what's the patient voice about assisted PD? This is one patient, one of our assisted PD patient, giving a talk about assisted PD during meeting. I remember that he said, when I started the treatment, I could do it by myself, but I lost my dexterity, and Isabel, his nurse at home, helps me now, and I can continue my treatment at home. This is one of my former patient who used to say that she could remain, she could stay at home and meet her daughter on the afternoon. And she used to travel a lot, and she told me that now she was traveling through the internet. She remained on PD, on assisted PD during 4 years at home. Then she was admitted in a nursing home for 3 months, still on assisted PD, and she finally passed away in a nursing home. This is my last patient, a retired farmer from Normandy, living in a rural area on assisted PD. And he told me, you should tell to your colleague that they should use, like in France, assisted peritoneal dialysis so that we can do our treatment at home.
Thank you very much for this great overview. So you know that this is a European webinar. So before handing the microphone to our Austrian experts, I have just one question. So how is the uptake and the practice of assisted PD in the European Union? Is it very different from one country to another?
Yes, there are a lot of differences between the countries. In the UK, assisted PD is provided by a technician, a paid technician, who is authorized to manipulate the catheter, even though he's not a nurse. He took a qualification. In Belgium, I think it's like in France, but they have to struggle a lot to get nurses who agreed to go to the patient home. I think that the system which is closer to the French system is the system that they have in Norway and Sweden. It's almost the same organization that we have in France. I must admit that in France we have a very generous system because nurses are paid to do 3 or 4 PD exchanges at home, which is not the case in most of the countries in Europe.
So, Professor Vychytil, how is it in Austria then?
Well, this is nicely summarized in this paper, which are shown by Thierry. There are only spots of assist PD. This is very difficult because of reimbursement and yeah, some centers do it, but in most of the country there's no assist PD, only family assisted PD.
Even if in France we have this very generous system with this tremendous advantage, I have to admit that the rate of PD in France is still very low, except in some part of France. So,
Except in Caen. Dr. Windpessl or Professor Vychytil, the floor is yours if you have comments or questions, of course.
Yeah, thank you, Thierry, for this excellent summary of important data. So you showed your recent study published in Kidney 360. And if I remember correctly, there was a time dependence, and it was a difference between family and nurse assist PD. So I think the transfer to hemodialysis because of infection was higher at the beginning, during the first 6 months in nurse assist PD, then it declined. And I think in family assist PD, it was vice versa. Could you briefly discuss possible reasons? Could caregiver burnout be a reason, for example?
yes, I mean, I think that during the first 6 months of peritoneal dialysis, nurse-assisted PD is a marker of the risk of being transferred to hemo. That can explain why the patient treated by nurse-assisted PD during the first 6 months have a higher risk of an early transfer to hemodialysis. And finally, I tend to believe that the family assistance is probably more efficient because family members are very involved at the beginning in the patient care. But I also believe that after some months on PD, they feel, I mean, the family helpers are, let's say, exhausted or there's a sort of burnout. So probably that could explain why there is a time-dependent effect of the assistance. That's my hypothesis.
So it could make sense to start with family assisted PD and then to transfer patients to nurse assisted
Correct.
PD, maybe.
Correct. Or to reevaluate.
Yeah, of course. Yeah. The ISPD position paper suggests to monitor caregivers in order to see burnout. So how should this be done? How is it done in your center? Do you give caregivers the possibility to speak about own problems, burden, maybe every 3 months? If looking at the data of Caen, we should do it maybe at least 3 months after start of PD. How do you perform this practically?
Well, I think that in our center, that's the nurse who are talking with the patient, trying to assess if if the family is reaching burnout or not. Yes, I agree. I mean, we need to talk with the patient regularly just to make sure that they can continue to provide help. But I also believe that there's a lack of research about this particular point, and that we should, that was one of the recommendation of the position paper, to study the effect of assistance, providing assistance on the family caregivers' well-being, in fact. Because after, I don't know how many months, but they feel it's like a burden. It's not help, it's a burden.
But I think it would be also important to talk to the caregivers without the patient.
Mm.
Do you
Yes.
agree?
Yes, I fully agree.
Yeah.
Yes, yes, that's a good point. We should try to, uh, but this is the case. I mean, I'm talking only of my of the practice of my center because we see the patient and during the medical meeting, the nurse they can ask the family members how they feel and this kind of information. But I agree that's a main problem.
One other short question. There's also device-assisted PD. So many devices have been developed for connection, for breaking the seals, even a cycler with voice recorder has been developed. Do you think that these devices are important? Will they replace person-assisted PD or is there no future? Also, remote monitoring, maybe that's another point, of course.
Maybe for particular category of patient, but in the same time, in a study that we did several years ago, we tried to use tools to investigate the patient dexterity, and the patient dexterity is really severely impaired. So I'm not sure that any kind of devices can really help those patients to manipulate properly the devices. Maybe it could work in a category of patient, but for every for all nurse-assisted PD patient or even a family-assisted patient, I'm not too confident. That's my personal opinion, but I have no evidence.
Maybe a last question, Dr. Windpessl?
I haven't any. My question has been addressed. It was about variations in the European scale, but it's very patchy, I gather, and very different with regards to legislation as well. So no more questions from my side. Thank you.
Oh, thank you to all of you. Well, Thierry and Clémence, you live in a very nice place. And the tradition here is to share a few pictures to show how beautiful your region is. So who is going on with this? Maybe Thierry?
Okay, so I suggest that if you like to walk, you should do the Sentier des Douaniers, which is the Great Walk 223 in the Cotentin coast. So that's a very nice way that follow the coast during, let's say you can walk during 10 days or 15 days along this very nice coast. You could appreciate the famous Rat Blanchard, which is a very big stream that you have at the end of this peninsula. It's very impressive. You can enjoy yourself on these very nice beaches that you will find along the way. This is my lovely woman doing backpacking with me along the coast. You see that you can put your tent in the field and stay for one night if you want without any problem. The French are very kind, so you won't be disturbed during your stay. And if you follow this way until the end, you will reach the Mont Saint-Michel. The Mont Saint-Michel is in Normandy and not in Britain. I want to emphasize this fact. But if you prefer to swim, you can come to Caen and run the Caen Triathlon.
So my message is come and visit our city of Caen. So we are here, and here you can see the harbor where you can have a drink, and also you can go to the market on the Sunday morning, which is a nice rendezvous. After that, here is the castle. So we are celebrating this year the millennium of the city of Caen. And near the castle, you can also walk in the historic district here with many restaurants also. And for those who love cycling, the Tour de France will be in Caen this year. So on the 9th of July, you can come and see the individual time trial cycling that will end in the Helitas Stadion that you can see here on this picture.
Thank you very much, Clémence. Thank you to both of you. This was a fantastic talk, and thank you to our co-moderators for their very interesting comments and questions, and see you for the next stage.